Okay, we're just a little late coming back, but thank you, everybody, for showing back up here. We're going to start the meeting, and as people trickle in, we'll just keep the testimony rolling. So the next portion of this, we're going to hear from consumers and advocates. Alyson Beytien, a parent of an autistic child and who receives autism services, sent a letter in, and Pam is going to read that. We have Jeff Edberg, parent of a Medicaid consumer, and Andrew Williams with AFSCME and the Iowa Home Care Workers Local, June Klein Bacon, chairperson of the Omstead Task Force, and also Ann Starr, who is CEO of Orchard Place. Okay, so Pam, will you lead off with reading Alyson's?
Sure. Thank you, Madam Chair. Alyson and her family live in Dubuque, and she wasn't able to make it today, so she sent a letter and asked if I would read it. My name is Alyson Beytien, and I live in Dubuque. My son Zachary receives supports and services through Heels and Dales, funded by Medicaid and the ID waiver. Zachary lives and works in a community with constant 1-1 support due to his diagnosis of autism and severe challenging behavior. I am also a board-certified behavior analyst working with individuals with autism through Hills and Dale's Autism HD program. The transition to privatized Medicaid has impacted my son and the families I work with in an unexpected and negative way. Service providers are not being paid for the critical therapy treatment authorized and contracted for. This creates the domino effect of service providers not being able to pay staff or provide treatment if they are not being reimbursed according to contracts and Iowa Medicaid rules. There appears to be the classic MCO delay, deny tactic for payment and reimbursement. Iowa has very few providers of applied behavioral analysis, the evidence-based therapy that provides the best long-term outcomes for individuals with autism. Those providers cannot continue to provide the needed treatment if not reimbursed in a timely manner or at the contracted rate. This will have a huge impact on Iowa's ability to add providers for autism at a time when the numbers of individuals with autism are increasing. My son Zachary receives a high level of support and services to allow him to live in our community and be safe. This level of support requires highly trained individuals, which also means a higher rate of reimbursement. The lack of payment to his providers may reduce his support, which in turn creates an unsafe environment for him and his housemates. The privatization of Medicaid has caused innumerable challenges to maintain and assessing the appropriate level of care for individuals with autism. The system was not ready. The MCO personnel do not understand the complexities of the disability world, and the blatant denial of payment and services will reduce services for our most fragile Iowans. Thank you, Madam Chair.
Thank you, Senator Jochum. I'd like to start maybe with Jeff Edberg. And Jeff, I've been reading the stories in the Cedar Rapids Gazette over a period of a year. They'll be following you, and they've really brought to light really the struggles that families have with certain aspects of Medicaid. So I appreciate that you participated in that because it really helps people see what's going on. So could you go ahead and testify, please?
Thank you, Senator, and thank you all for the invitation and for your efforts. Without what you do, we really wouldn't have a hope for our children. And thank you for noting this spot that has been appearing in the Gazette. That's a small targeted part of the story. It's about what is happening to a family with disabled children under this system of managed care. I'd like to back up a little bit, though. I adopted Colin and my other son, Liam, through DHS. Those are special needs adoptions. There's a deal here that I said, I will take these kids and love them and take them in my family. And the state said, we will cover the known and unknown problems that are going to occur. And I kept my promise and the state didn't. What's happened, see, the whole deal here is they have an entitlement. That's not about them, it's about us. It's about what people we want to be. Are we going to be the people that disregard disabled and disadvantaged people, or are we going to be the people that take care of them? We've made a decision, we're going to be the people that take care of them. Within limits, there's a limit to the money, we get that. There's got to be a way to tame escalating costs. Part of that decision, though, I'm not hearing talked about, is 55% of this $4.2 billion is paid by the federal government. That's not our bill. That is a joint bill because the federal government believes in this vision too. That one way to solve the escalating cost of medical care is to capitate it. That's what we've done with the managed care system. That means, okay, MCOs, here is $4.2 billion. I don't want to hear any more about it. That's what you get, make it last. Now, as part of that, we had one of the most efficient systems of medical care delivery in the country. Our cost of service for this $4.2 billion that we're doling out was 4%. That's $168 million. That's a lot of money. But that's what it costs to run IME under the entitlement system. Fast forward to a capitated managed care system, which does not manage care. It manages payment. The instructions are, you take this $4.2 billion and spread it around and make it last. And incidentally, instead of paying you 4%, we'll pay you 15% of that. I don't want to be a spoiler, but I'm dying to be a spoiler actually, but I'd be curious to know of that $630 million that the MCOs are receiving as their 15%, are they delayed 90 days, 120 days in their payment receipts? Just saying. So under our old system, prior to April 1, we had a little over $4 billion to spread around and take care of the kids. Now we have $3.5 billion. Is this saving money? Yes, it's saving money, but who's paying the bill? The people that cannot defend themselves are paying the bill because they can't talk back. Now, when I adopted these kids, I took it seriously. And with Colin I put pictures around of Colin. He is a darling boy. He had his 14th birthday on the 4th of July. He has quite a sense of humor. They give him meds at school, and they have to check his name because of protocol. Say, is your name Colin? And he said, no. He said, what's your name? Mommy. And it's just, he's got quite a sense of humor. He's operating with an IQ of about 50 and an emotional age of 4. But he is thriving, he's existing, he's having a good, happy, meaningful life in his environment. He lives in Dubuque. It was it was the hardest day of my life to take him. Sorry, but it was the best thing for him. And because of this deal, I knew that I am going to certainly, or he's going to certainly outlive me. He'll have problems long after I'm gone. And so I want him in a place where I can rest that he is taken care of. And with Medicaid standing behind Hills and Dales and Hills taking care of Colin, I was assured that he would have a job. They would take care of him. He will not time out in this facility. And he was good. I go see him every week. We talk during the day. I do most of the talking since he's pretty much nonverbal. But we have a real relationship and a real family. And as of April 1st, that's over. What I did, that's just, okay, Jeff's upset. But I thought maybe some notes would help. And I have names, times, and dates, and I'd like to tell you some of this without the names, and I'd be happy to give this sheet to Senator Mathis for the record so that you can have all the information. When I first started investigating this, I also have a second son that is on growth hormone. I adopted him from DHS. He was had a terrible first 9 months of his life, and he has to take some very expensive drugs because of this, part of his life. So the instructions were, as a parent, to review the drug list for each of 3 MCOs. At the time there were 4. Now there are 3. Those drug lists are PDF, they're non-searchable, and they're 45 pages long. So I read every one of them to see what what medications are approved. So I found that AmeriHealth Caritas approves this particular growth hormone. Great. I called them to confirm that. They said that it's not a prior approval, that they would be covered under the Medicaid rules for 90 days after April 1st. And after that, this medication would need a prior approval. It would take 24 hours to get a prior approval. Say, great. Sounds good so far, doesn't it? Didn't work out that way. Then I called on January 21st to check up on some of these changes, because I also drilled down and read all the bid documents to see what this MCO business is. And it was fairly upsetting to get into the underbelly of what is really promised in the fine print by the MCOs. So I called a particular person at IME on January 21st at 4:31 and was told that I was really overreacting, that the only change here is going from, that all the documents, they're changing the word Title 19 to MCO in the documents, and that's it. That's the only change. And I said, you're kidding. You're kidding. You're going from an entitlement system to a capitated care delivery system. You're making the underprivileged, the children, the disabled people pay for it. And you're telling me that it's a title change? And she was very flip and said, yes, that's the only difference. I have her name for you. So I signed up my younger son that needs the growth hormone. And I wanted rate information to make sure everything was okay. And they said, well, we don't have any rate information because we won't have an apartment until April 1st. And I said, there's a little problem here. April 1st, he needs that medication. I can't stockpile it. I can't go to the pharmacy and get it. This is ordered in advance and shipped per doctor's orders. The first exception to policy was signed by Director Palmer at DHS. And so this is a long process. He's been doing this for 4 years. And they said, well, we can't give you any information until April 1st. I said, what do I do April 2nd? And they said, well, it's not 24 hours. It could be 90 days for prior approval. Moving on here, then I I put my submission in to select MCOs, put both names on the submission form, sent them off to IME. I got one back for my youngest son, but not for Colin. So I called IME and again talked to a young lady at 2:30 in the afternoon on 3/19/16 and said that, well, he's not assigned to an MCO. And in addition to that, I'm not authorized to ask questions on his account. And I suggested I was. I'm his dad. She said, well, she'd have to get a supervisor on the line. That they couldn't find any of my information, and that he was not issued, they haven't issued any MCO letters. And I said, I'm holding one in my hand. And they said, oh, well, as long as you're holding one in your hand, maybe we have. And that, so I have one for my youngest son. I want an assignment for my older son. She said, well, that comes from the MCO. And I said, actually, it came from IME. And she said, oh, in that case, we'll get a letter to you right away. Which is it? I mean, what's going on? There's no substance. There's no firmness. Nobody knows what they're doing. Fast forward, 4/1. We're rolling out the MCO system. Colin lives in Dubuque. He was also taken off mysteriously the HIP program. He totally qualifies for HIP, so does Liam. And in November, they were both taken off the program because they didn't qualify, which according to any guidelines I can hear, they do. But I find out later that if you're on the HIP program, you will not be assigned to an MCO. Is there a strategy there? Maybe, maybe not. In any case, so I canceled his well-marked policy. I was covering both boys under my insurance. So now it's time to assign an MCO with Amerigroup. There aren't any. The doctors in Dubuque hadn't signed any contracts, and so the closest physician for him was in Galena, Illinois. Now this is a kid who has seizures. Can you imagine getting a call from Findlay Hospital and saying your son is in intensive care? Actually, he was in the emergency room prior to intensive care. We don't know what's wrong, but you better get here right now. That's a trip to take. That time he was having seizures. He fell and he's nonverbal, so he can't tell anybody. He has microcephaly. He has cerebral palsy. He has hypertonia. He can't grab things. He's nonverbal, and he's on the autism spectrum. So somebody's got to watch out for this kid. I got on the Amerigroup website. I noted all the doctors within a 25-mile radius. There were 6. 4 of them were in Galena, Illinois. So I called the clinic in Galena, Illinois, and I think 2 of them were board-certified physicians. The rest weren't doctors. And I said, you're not getting this. That with his disability, they wouldn't take him anyway. The other 2 listed in Dubuque wouldn't take him. So there are no doctors for this medically fragile child within 25 miles, and I only say that because that's the radius that the search tool went. Now, the rules are that he had a primary care physician, a very gifted primary care physician that knows him, and that's very important with a kid like this, that because you got to second guess him. So he got sick. He got sick with a staph infection that went into his blood. That can kill him. And so am I concerned? Yes, I'm very concerned with this. And so I sent him to his primary care physician. They get him. They care about him. And knowing that he's not in their network, they finally, after 4 days, signed with AmeriHealth Caritas. And so immediately I went to switch him. It takes 30 days to switch him. So he is now for 34 days not in the network. The doctor didn't care. He's cut back to 90% of his fee anyway, but he didn't care. He's a doctor. He's going to take care of this kid and save his life. His nurse, I talked to his nurse. She was not nursing people. She was not caring for people. She was getting prior authorizations for him and other MCOs. That it's a paperwork system. You've got to do all the paperwork, and this kid is going into the ER. He had to have a brain scan and other tests to make sure he wasn't going to die. The doctor didn't care, and it was just red tape and paperwork that delayed him. Now, I switched him to the network, the managed care network that this doctor group is in, and I got a letter from them, and then followed by another letter on 4/18 switching him to Amerigroup. Well, I didn't do it. I mean, why would I do that? So I called Amerigroup, said, who switched my son? They said, we don't have any, we see that he switched, but we don't have any record of who did it. So I called IME. They said, we don't know. We see he was switched, but we can't tell you who switched him. I said, this is crazy. And I understand there's actually 2 ombuds people that serves 560,000 people. So I asked for the number. They laughed and gave it to me. I called it and got a fast busy, which means I couldn't even get out of Iowa City on that line. There was nobody to help with this situation. But they weren't willing to switch him back to the group he was in because that would be against the rules. And so you can't switch an MCO for another 30 days. Nobody knows who switched him away from the one his doctor was in. And so now that's 64 days that he is out of network because of red tape. Here's a question, it's a rhetorical question, but why 3 managed care organizations? Why am I in this dilemma? Why can't I sign up for all 3? Is it really a shell game where people will get tired of trying to play this game and give up? That will certainly save money. Okay? So it goes on. I called for a supervisor when he was switched to Amerigroup. I was hung up on. I was told I'd be called back. I said I've called both AmeriHealth, Caritas, and Amerigroup 5 times and been promised to call back and never got a call back from anybody, any time. My youngest son needed, the 401 came around and he needed the injectable medication and he was denied. Now this is the exception policy that Director Palmer had signed under DHS rules. Well, they denied it. And I was willing to pay it, but it's expensive. It's $4,500 a month is what this stuff costs. And Blue Cross pays about that, and I was asking the MCO to pay $77 is what their part had been for the last 4 years, if they'd bothered to look. But they said, well, it's been denied. The claim's been denied. And I said, well, he needs the medication. I'll send you the $77. But I can't move ahead because you're stopping the progress of this claim. I called the online pharmacy. It has to come from an injectable pharmacy in Nebraska. And they said, we're so sorry, Mr. Edberg, that we are so tied up processing claims. We got 20 of prior approvals that we're wading through paperwork to get approval on. And so we can't send it to you. I finally got a supervisor at Caritas, and I said, look, you didn't read the file, first of all, because the primary payer is Wellmark. That your part is $77. I'll send you the $77, just approve the claim so we can move on so I can get my son this medication that he needs. And she said, well, hold on, and came back in 10 minutes and said, well, it's approved. Now I ask you, what kind of medical process is that? If in fact that they're reviewing claims in the back room with a physician and everything else, or is it just about that it's $77, not $4,500? It's a rhetorical question.
Mr. Edberg,
when I had the...
Mr. Edberg, I hate to move you along, but we've got about 15, 20 minutes left for the other 3 people to testify as well. So, I appreciate your
Senator
story.
Mathis, I appreciate that. I think I've given you the flavor of the daily struggle that we have with this system.
Yes, you do have a daily struggle. We can see that.
That when as far as the 8 days payment that he was calling, we applied for submission on 4/1, and I got a letter of approval yesterday. That's 120 days for approval, not 8 days.
Let me ask you this in generalities. It seems like a huge struggle, every single step you take. It seems complicated, and you're hitting brick walls. And for your case, because you have complex cases, your children have complex cases, is there anything that would make this work? Is it the pre-auth? Is it getting to someone who knows your case better and a consistent person who you could call? What is it that would make this better?
Thank you for the question, Senator. And what can we do with what we have to make it better? It got real for me, and I don't know. I don't have an answer for you. This system is not going to work, is the problem. This system is not designed for disabled people. That Colin isn't going to get better. And so the governor's letter here says that, well, kids aren't getting better. Well, no, they're not getting better. They're not supposed to. They're disabled. They can't get better. And so that was his basis for implementing the MCO system. What could help is if we have 3 MCOs, let the recipient sign up for 3 MCOs. Then we don't have the shell game. Colin sees 8 different suppliers or providers, and I'm hoping they're in the same network, because if they aren't, he doesn't get service for it that he's entitled to. That would solve it, or that wouldn't solve it, that would help. If we roll back and simply reenact the Medicaid system that was working and look for efficiencies, look for ways that we can cut that. The estimate I've heard is that the cost of Medicaid in 17 will be $5 billion. Medical costs are soaring. We know that. Let's fix that. Let's look for ways to fix that. But let's not make the kids and the disabled and the people that cannot defend themselves pay for it.
Thank you for your testimony. This is just a frustrating time for your family, and I apologize for what you have had to go through, and I sympathize with you as well. Up next, let's have Andrew Williams from AFSCME and Iowa Home Care Workers Local.
Thank you, Madam Chair. Just as a quick reminder, I'm here as a representative of AFSCME Iowa Council 61. For the past 10 years, we have been the representatives of individual CDAC providers in Iowa, and CDAC is the Consumer Directed Attendant Care Program, which allows for Medicaid recipients in the waiver programs to get help with day-to-day tasks and chores, and some targeted medical help to keep them in their homes rather than going into a nursing home. I have spoken previously to this committee about the CDAC program and how this transition, if not properly prepared for, would hurt people. And I regret to be here again to speak about the ways in which providers have been hurt by this transition due to problems that were completely avoidable. It is clear that this privatization process was rushed, and that has resulted in devastating circumstances for hardworking Iowans who care for the most vulnerable among us. After appearing before this committee last November, AFSCME was assured by Iowa Medicaid Enterprise that payment issues for providers would be a smooth transition. We had been assured that the method for paying providers would remain the same. The IME would be able to share payment remittance information with each of the managed care organizations to ensure that the providers could still receive electronic payments to the account of their choice, just as had been the case for the past several years. Unfortunately, months later, it turns out that wasn't true, as IME had made no effort to ensure that providers would continue to be paid electronically to the accounts that IME already had on file. Since the transition, we have received countless phone calls from providers with payment issues. People have gone without a paycheck for months, have been forced to have utilities shut off, have been threatened with evictions, and have put themselves in debt just to make ends meet. Call after call, we have tried to do what we can to sort out problems with payments, whether they're checks that haven't been received after weeks or, like I said, months at a time, or claims not having been received, or payments being hundreds of dollars less than the amounts claimed. And again, these are individual people who aren't paid much to begin with, so if you go few hundred dollars short, that can put a big wrinkle in things for folks. Checks have been sent to addresses on file that haven't been used by the provider in years. Inaccurate payment rates have been provided by IME to the MCOs. You name it, we've probably gotten a call about it. While I could speak for hours about these issues, our concern is making sure that we do everything we can to fix these problems as soon as possible and make sure there is a quick resolution to problems that arise in the future. I want to take a moment to say that my experience so far with most representatives from the MCOs has been a pleasant one. Particularly, I've been very impressed with the responsiveness given to me by United Healthcare. While few of our calls have been from UHC providers, they have been very attentive to problems brought to their attention, and for that, we are grateful. It's nice to be able to tell a provider that their issue is being fixed. I know that many of the people at the MCOs working to sort out these problems are just as exasperated and frustrated by these problems as I have been, but our frustrations pale in comparison to the providers who require us to sort out these problems just in order to keep paying their bills. Their work matters, and it's unacceptable for them to continue to go week after week, sometimes months, without us fixing these problems. Some of the larger problems that we need to address: providers need help in making sure they're signed up for electronic fund transfers. The EFT forms should be streamlined to reflect that these are payments to individuals and not to large agencies or clinics. Forms should recognize that these individual providers have their Social Security number as their tax ID and not an employer identification number as associated with the business. All forms should be able to accept an NPI number which begins with an X, as all CDAP providers have, instead of a number. Again, remember, CDAP providers, these are individuals, and they don't have the resources that large hospitals and clinics have when they run into these payment issues. They have themselves and us, and that's it. Claim forms should be universal and not MCO specific. Any changes to claim forms should be phased in over time with a grace period, as opposed to adding a signature line for a client and then denying claims because the signature is not present. Providers have been doing this work for years and have never had that requirement, so it's not surprising that this has caused some payment delays. There are dozens of reasons why a client might not be able to sign a form, so we have concern over those kinds of requirements being used to deny or hold up payments in the first place. But that's a whole other discussion. The point is, changes need to be brought to the attention of providers and phased in rather than implemented immediately. Of course, if these issues and concerns had been discussed prior to the transition, it's possible that these problems could have been avoided altogether. Unfortunately, that was not the case. I'm most disappointed in the role of Iowa Medicaid Enterprise, both before and after this transition. They have been little to no help. Our concern with continuity of payments was not heeded, and our requests for help in sorting out individual payment issues have been ignored repeatedly. These are serious issues affecting real people, and AFSCME will continue to do all in our power to ensure that these problems are resolved as quickly as possible. I hope everyone here will do so as well. Thanks.
Thanks, Andrew. Up next, June Klein, Bacon, Chairperson of the Omstead Task Force. June?
Thank you, Madam Chair. And just to add to who I am and why I'm here today, I also serve with the Brain Injury Alliance of Iowa, serving 22 counties in northeast and north central Iowa. In addition to that, I am also a foster parent. So this transition has affected me not just in my work life as an advocate, but also in my home. So there's a lot of different hats that I wear that this has affected me. This transition, I frequently think about as just happening too big, too fast, too much at once for families, for members, and for providers. I think that, you know, I could provide varying degrees of inspirational rhetoric to try to inspire and try to be impactful. But what I deal with, as many of you do on a daily basis, is calls about how do I fix this problem? How do I keep from losing my services? And I can just add to the stories that you're hearing today. And in the interest of time, I'll try to be brief. You know, I'm hearing concerns from people that are nervous about moving things up the chain because they're fearful of retaliation. They want to be sure that they're working with providers, with the managed care organizations. And so when they call me as an advocate, I'm working with them to try to understand what are the processes to do appeals, what different departments can you ask for help from. And it's been very confusing to figure out what are the processes and who can we ask for help from. A couple of examples that made it very clear to me that cuts in services were coming were calls from case managers to my office saying, we're at our 90-day review and we have to evaluate how we can decrease services to save money. Those were words that came to my office. You know, one of the examples was to move individuals that were getting out-of-state services back in state. Now, I will be the first to tell you that I would much prefer that a person be getting services in state, in their community, near their homes, near their families. I will be the first to advocate for that. As a representative from Omstead, I will tell you that the least restrictive environment is very important to me, but there is a reason that people are getting services out of state, and that's because we lack capacity of services here in the state of Iowa. So to hear somebody call my office and say we need to figure out how to move this person back in state to save money is very concerning to me. That's a very concerning statement to me. And when I moved that statement up the chain, I was told, at that particular managed care organization, I was told that that statement should not have been made. The issue that I have with that is whether it should or shouldn't have been made. That's the culture that those folks are coming to us with. A couple of instances and calls that I'm getting are parents that are having to provide services for their kids with disabilities, and I'm talking about adult children with disabilities because their services are being cut. A few weeks ago, prior to the Cedar Falls listening session, I got permission to share a situation. An elderly mother was having to provide services for a 50-something-year-old child with disabilities because her 24-hour care got cut to 12 hours a week. That's not okay. Okay? I'm currently working with a mother who has a child out of state for mental health reasons, and a utilization manager for the managed care organization is indicating that they have 26 days to discharge and bring her back home, bring the child back home. The team, including the managed care organization case manager, has indicated that this child is a threat to the mom, and the team has come to the conclusion that her only option is to give up rights to her child and put her in the state system. Not okay. Okay, so these are just some examples, that I bring to the table, and in the interest of time, I'll go ahead and pass on. I certainly am more than happy to answer any questions if there are any.
June, thank you for representing. Ann Starr, CEO of Orchard Place. Ann?
Thank you, Senator Mathis, and thank you for sharing what you did today. It was wonderful, very compelling. My name is Ann Starr. I'm the CEO of Orchard Place, a child and adolescent community mental health center and nonprofit agency serving more than 10,000 youth and their families annually. Orchard Place has a continuum of mental health services from prevention, outpatient, community-based, and psychiatric residential care, or PMIC, as it is called. Orchard Place is committed to the safety of Iowa's most vulnerable, seriously mentally ill youth, and I appreciate the opportunity to share here today what we've experienced so far about the impact of the new Medicaid plan. I want to make it clear that we have a long history of working with Medicaid and a long history of working with behavioral health managed care. We've been working with Magellan since it came into the state in 1995, so for that entire 20-year period, had a partnership with that company and are very comfortable with managed care concepts, and also with the what I would call tension that exists between funders and providers. This is different. What's happened since the transition to the new Medicaid plan, Orchard Place is awaiting payment from the MCOs in the amount of $978,370. This is about 1/3 of our Medicaid billing since April 1st. So just a little shy of $1 million. And it's broken out on your sheet there in terms of which MCO is responsible for which amount. Also, PMIC therapy and nursing staff have more than doubled the time that they spend on the phone to have services authorized. It sounds like something you've heard before today, and it takes them away from client care. I had a therapist last week in the hallway in our residential program stop me and just really, really deflated, say, I have spent more time this week on the phone with managed care companies than I have spent with kids. Not why he gets up in the morning to come to work. Thankfully, whenever we have asked to meet with the MCOs or asked for clarification or attempted to unravel broken processes, we've had a response. MCO care management staff have visited our PMIC program and some have even participated in child staffings and meetings via phone. MCO staff appear to be making their best effort to keep and improve processes and communication and to pay claims. It appears as though a lot of effort is being expended on the part of the MCOs, as well as our staff, to resolve these issues. The most difficult processes to resolve are those, and this has certainly been our observation, that involve the out-of-state MCO staff. So when we have to call to get authorizations either for pharmacy or medical or mental health procedures, that it is the most difficult when they have care management and entities that are operating out of state, and lots of call transfers and call drops. And that's when we don't get called back. Since June 30th, when the transition period ended for the MCOs, so that first 3 months of transition and payment, 5 of the 18 United Healthcare youth in our 88-bed PMIC were very suddenly decertified. None of the other 70 children have been. Since July 1st, there are 40 days where these 5 youth that were denied payment have remained in our care, and we will not be reimbursed. We have scheduled a meeting with United Healthcare to discuss how to better prepare for these transitions for children so that neither the family, the child, the schools, or their local healthcare providers are surprised and they can be ready. I believe that these are minor issues that can be problem solved if UHC is willing. We can do quality transitions for these very high need youth. But most concerning is UHC's denial of payment for PMIC for a young man who we'll call Robert. Just days before United Healthcare's denied payment for Robert, he had just returned to the PMIC after an inpatient hospitalization where he was at serious risk of harming himself and others. Robert still needs PMIC level of care. So far in the appeals that we have filed, we have lost those appeals and the original denial has been upheld. The discharge plan offered by United Healthcare was for Robert to return to his grandparents' home with outpatient therapy and in-home skill building, something that we know is not safe nor going to be very helpful to Robert at this point in time. He's safe today and getting the care he needs because we're paying for it. We can't do this indefinitely. Most troubling is what it says about UHC views of youth like Robert and how they view PMIC care. In our August 10th meeting, which is when we're scheduled to convene, we hope to work toward some middle ground and understanding on United Healthcare's desired outcomes for kids, desired outcomes for PMIC treatment, and how we can work together to get to those outcomes. What steps have we taken? We are working on partnerships with the new MCOs. While we understand there's always tension between an MCO and providers, there are lots of opportunities to leverage our collective expertise and resources to improve services. But timing is everything. And we've waited for more than a year to have the ability to bargain with the MCOs to address critical issues and areas of concern for PMIC and fundings for alternatives to PMIC. Timing is everything, and we need action. In fiscal year 2015, we downsized from 103 PMIC beds to 88 beds. The rate structure had been based on cost settlement. Reducing the number of beds and accelerating treatment to reduce time in treatment logically increased the per diem costs. We approached Magellan several times in the spring and summer of 2015 to address these critical PMIC issues. We were told by Magellan that IME would not allow during the procurement and then transition from Magellan to the new MCOs any provider contract changes. So we were told we were prohibited from, 1, addressing rate issues, or 2, contracting for alternative services to reduce PMIC. Last year, while we waited through the transition, the Orchard Place PMIC lost $453,000, and we're scheduled this year, budgeted this year, to lose the same amount of money. We need action. We need, 1, PMIC rate relief and better understanding of what number of PMIC beds the MCOs need. So when we've met with all of the MCOs, we've asked them, have they looked at the data? Do they have some kind of idea about ideally what size or number of PMIC beds they need in the state or in central Iowa? They do not. We need for MCOs to define criteria and desired outcomes for PMIC. It seems very unusual that we would have 3 dramatically different sets of criteria for admission and continuing stay for a level of care like PMIC. And clearly, we have one of the MCOs that has a very different set of criteria for PMIC than the other 2. We need to contract and pay for effective home and community-based therapies that reduce reliance on PMIC, and actually that fulfill the requirements and recommendations that have been made in no less than 3 children's mental health work groups over the last 6 years. What happens without resolution? 1, we lose a critical part of the already fragile children's mental health continuum of care. We will have to close our PMIC beds. We lose the expert team of our PMIC staff who will be laid off. Critical infrastructure is gone then and nearly impossible to rebuild if or when someone realizes that there is a need for it. And 3, we fail mentally ill kids and continue to reduce the amount of funding allotted to mentally ill youth, a population we know already is underserved. Orchard Place has a piece of data that tells us that PMIC is still a needed service in Iowa. We received more than 500 serious referrals, so that's more than just a frustrated mom calling after a bad weekend. These are serious referrals annually, and of those 500 youth, 200 are approved and then admitted into PMIC. 30% of these youth admitted are from central Iowa, but the other 70% are from all over the state. We need to see resolution, and we are very willing to partner. It only makes sense that if we can deliver alternative services that are evidence-based and less costly than PMIC, which we've offered multiple times, if we reduce our PMIC beds but get some rate relief so we can continue to offer some of the same high-quality service that's successful. By the way, 95% of our PMIC youth go home. It's a win for all. Overall costs decrease, the system of care improves and moves toward home and community-based care, and the state decreases reliance on out-of-home care. Thank you.
Thank you, Ann. Very powerful testimony by all 4 of you. Committee members, questions of these 4. Senator Bolkcom.
Yeah, thanks for the testimony. Really just an observation about the testimony we've heard today. I know we're going to have the MCOs later, but we've heard from some of our biggest, most important healthcare providers today across long-term care, across hospitals, across taking care of our vulnerable kids. We've heard from consumers about some of the issues faced by families, and this isn't some little anomaly over here. This little problem that's cropped up in this major change. This is a huge problem of the rollout of this. For months we've said this is, 1, it's a bad idea, and 2, we're not ready, but from everything I've heard today, this couldn't be going worse. This was a self-inflicted decision by the governor, Governor Branstad's decision to move ahead on this with lots of opposition and like zero collaboration with the legislature. I appreciate Senator Johnson stepping out and raising concerns. I wish other members of your party would get involved here, because I think the governor has no clue what he's done here. And I wonder if has anybody that's testified here today, or people that have joined us, has anybody tried to get a meeting with the governor to talk to him directly about the consequences of what he has put in front of us here? Has anybody, can I see? I would encourage you, if you haven't gone to the governor's office, because I can't believe that, I mean, he is so out of touch about this, that these problems are deep. And I got to say, I don't really, I mean, we're going to be back here in a couple months. Senator, we wouldn't be here today if it weren't for Senator Mathis wanting to bring us together for our Democratic caucus and have a time to share and learn more about how it's going. And we'll be back. But I have in 6 to 8 weeks, 3 months, I don't think we're going to be doing any better than we are today. And at some point, something's got to give here. This governor needs to take some responsibility, and if he's set on going forward, he needs to put some people in charge of this that can get the job done. The concerns today are huge, and we're going to hear from the MCOs later. I think that's going to be very unfulfilling, and these problems are just going to continue on. Our job in this oversight process is to try and bring some attention to this, and I just have a feeling this Governor Branstad is clueless about what's going on here, and he needs to hear from people in his office directly to get his attention.
Senator Johnson.
Thank you, Madam Chair. Senator Bolkcom, that's former party, by the way. And this is one of my reasons. It's not funny. It's not funny. This is one of the reasons I declared myself an independent. We have a responsibility as well. Ann Starr is absolutely right. We need action, but we need to be part of that. We haven't been since the beginning, except for our attempts to terminate the contracts, to take another vote to provide the oversight, which I'm glad that we have. We have to do more than that. I mean, I'm going to talk to the MCO representatives when we get up here. I want to have time to talk with them. But we have heard enough today, and I've got additional comments by a hospital administrator here I want to talk about. But we got to sit down and do this. I mean, what we're facing, if we don't, we're going to be coming back to the same meetings. I've invested a lot of time in this. I'm not really here officially, but I've spent a lot of time on this in my career. I'm going to continue to spend a lot of time on it. But we got to do something. Right here is we've got to do something. Okay. We've got to come out of this meeting today, Madam Chair, and all the members here, and do something. To think that you could do this in 9 months, and then we get these press releases from the governor's office. I mean, they mean nothing. They mean nothing. Because, they just don't, we're modernizing everything, they mean nothing. And these people don't mean a whole lot either, except they're advocating for the people we really need to get to. I understand what I'm saying here. You're here on their behalf, and I'm proud of you, that you continue to do this despite everything. But I have some additional questions when we get the MCOs up here, but because you brought this up now, Senator, I want to work with everybody. I want to work with you, and we need to do something, and the governor better get himself or his staff at the table. This is and I know that DHS is working as hard as they can too. We're trying to get this thing done, but there are specific things that can be done that are so simple. That's what I want to talk to the MCOs about. So simple that you would think you could have one meeting and say, let's find a way to address this issue and this issue and this issue, because having these 3 managed care organizations, as this hospital administrator says, puts health care for the least among us, for those who really need the help, and they're out there, on a foundation of inefficiency. Okay, thank you, Madam Chair.
Thank you, Senator Johnson. Anyone else? You've brought to light, again, to reiterate what Senator Johnson is saying, we're shining a light on this to take action. We've got to take action on this. The governor declares states of emergency. This is a state of emergency. This is a state of emergency. I think, we saw the hands go up for all the providers who are here. You're concerned, and I thank you very much for coming and supporting the people that you take care of, and for the 4 of you, the people that you represent, and Jeff especially, for your children. oh my goodness, our heart goes out to you. But we need more than just our heart going out to you, right? We need to take some action here. So thank you. And now we'll have the MCOs come up and answer some questions. We'd like Kim Foltz from United Healthcare, Cheryl Harding from AmeriHealth, Cynthia MacDonald from Amerigroup, and then if DHS and IME could be in the wings, that would be very helpful. Jeff has given me this handout, and I will make copies and we'll make it available for everybody, DHS, IME, the MCOs, and then everyone in our committee. And it documents just all the things that he did along the way to try to solve some of his problems for his children. So welcome. Kim, you want to raise your hand? Okay, Kim Foltz is with United. Again, Cheryl Harding. Okay, is with AmeriHealth, and Cynthia MacDonald is with Amerigroup. The three of you have heard testimony today from providers and from advocates and consumers. I'm going to ask you to stray away from your opening statement at first and tell me what your reaction is to what you've heard today.
So my reaction is this. The providers, the members here who are talking about their reality is real to us as well. What I can say is that in the implementation, in the build of a large program like this, I've done it several times, there is an initial phase of this where it's the building of the infrastructure, it's the getting it ready, it's putting it together. And then you start working there could be systemic issues that you work on. PMIC would be a good example of that. It could be very case specific to a member, to a particular provider type. I can guarantee you that in the provider information that you heard, I could probably talk about the other side of that story in terms of what has been paid, what hasn't been paid, how many days. I could go through any of that. I mean, I don't know if I could personally go through each of those today, but certainly I could provide that information. So the overall message is that we are building, we are working through the process of implementation. It is a process. It's something that builds along here, and that it does get better. That is the guarantee. It does get better. So I'll stop with that.
Go ahead.
I would echo my colleagues' comments. We are in the very beginning of the transition of a very significant program change. And it is always difficult to go through significant change. And we feel as much hardship about cases or people that are struggling to find their ways through it. And we certainly reach out and try to help that situation. I would not say that the first 3 months of this initial transition has been perfect, but I would also say there are positive stories along with the negative stories, and that we have worked to quickly and appropriately respond to the issues that have been brought to our attention or that we found on our own, and worked to address those, and will continue to do so. And just like all change, It will be tough at the beginning, and it'll get better and better as time goes on. And certainly for anybody that's having, any member that's having a specific concern or issue, we would want to hear about that. We do have, for the gentleman was up here, and I'm sorry I could not hear his name, was up here, we do have care managers that can reach out and help, and we would certainly be happy to do that when we become aware of those types of situations. So we do want to hear from people. We want to hear feedback. We want to hear what's not working. We like to hear what's working, but when we hear what's not working, it helps us be better and to grow the program and to get to the goals of improving member outcome.
Cheryl, Kim?
So I would echo exactly what my colleagues had indicated as well. And United Healthcare, our commitment is to our members. They are our top priority. So to listen today is really important, and we are committed to listening, and we're committed to taking action. So as we sit here today, we're here today because we want this feedback. We've been conducting thousands of meetings ourselves, working with providers, working with members. I would echo, we have just as many, if not more, stories of positive impact that we've made on our members to date in these first couple of months. And so what we're hopeful for is that we can have a good, thoughtful, objective dialogue about how we work together to partner to ensure this program's overall sustainability, with the number one focus to ensure that Iowans get the care that they need when they need it in the right place of where they need it. And so our commitment today is, and as always our commitment, is to our members to ensure they get that care.
Did any of you have opening statements that you wanted to make, something that you wanted to get across? Do you have opening statements that you'd like to start, or anything more than that? Okay. Okay.
Sure.
Go ahead.
No,
Go right
go
ahead.
No, I was just going to say, I think we've kind of said our general overview or approach to it, so I think we'd be okay starting with questions.
I think questions we would, to that, it's, let's talk. Let's talk about these questions, talk about your concerns to the extent as a CEO I can address, or any of us can address the detail. I'm happy to do that. But it also could be something that I need to, take back, figure out. Certainly member-related issues I would not be able to address certainly specifically because of member confidentiality. Provider-related pieces, we'll see how far we can maybe get with that if you've got questions around that. But I operate in particular in an area of transparency. Oh, I'm sorry, they're not hearing me. Transparency is very real. It's real to my company. It's real to me. And so at the end of the day, I am accountable for this book of business for Amerigroup. It is meaningful personally, professionally. It is the profession I have chosen to do, Medicaid managed care, very deliberately. And it's something I believe in. So I am more than happy to try to answer your questions, or certainly to do any follow-up.
Senator Garrett, first question.
Thank you, Madam Chair. My first question, I think, is probably a question that most of us are wondering about here. I understand that all three of you have programs operating in other states, and you've had experience with managed care. I'm wondering what you can tell us about the time frame as to when we'll be through the transition period. I mean, I think we all understand that a big program like this, everything's not going to go smoothly. But when will the transition be over? I mean, and I don't expect a date exactly, but how long is this going to take before we don't hear these kinds of complaints anymore?
I think it's a difficult question to answer, like you say, what's the exact time frame? But it does evolve, and right now we're in that phase where everybody's getting used to how do you pay claims? How do you get your claims billed, and how do you get them paid and in the right way? And that's a normal first step, and it's a shared responsibility by all parties too, because some of the rules have changed, or some of the edits are different, or things like that, and we're all learning and having to learn that piece. But the program will continue to evolve into, one of the purposes of this program is to move into more of a value-based purchasing environment, which means we pay for outcomes, not on a fee-for-service basis necessarily, long-term. And so there'll be changes that'll continue to happen as that that process moves as well. For total stabilization, I mean, you know, I've seen them be 12 to 18 months long. I mean, we certainly have which doesn't mean the same issues are being talked about. It means that as the program evolves, different issues are being talked about. But that doesn't mean they're always negative or problems. And I think, I can tell you from my personal experience, this implementation, and I know it feels tough when you've listened to things from today, but this implementation is smoother than many. This has been a pretty fast progression so far, and compared to programs in some other places that I've been involved with, not even at AmeriHealth Caritas, but other places in my career, you know, I think we're all committed to moving through this transitional phase very, very quickly, because we understand how important it is to the state and to our members.
So I would echo, when we look at programs across the country and transitions, and particularly the size and complexity of this program, I look to some of the comments we received from CMS, where we really did get positive feedback on this transition. And we are still working through a transition. We will continue to evolve. But I think there's some good data metrics we can point to that we are moving in that direction very positively. When we look at the number of phone calls we received on day one versus where we're at today, they're nearly cut in half. When we look at, when we break down those denials month over month, and we're educating and working with providers to understand some of those differences, there's dramatic decreases that have transpired over the periods of time. So we're going to continue to work. There isn't an exact date, but there is certainly very good progress that is being made. And again, our commitment is to work with providers and members to ensure we're getting their questions answered, and we're assisting throughout the process, because ultimately we are looking to drive value into the healthcare delivery system. This will not be a volume-based system, as Cheryl alluded to. We are working through that in a target to move to value-based contracting, so it's important that we're focused on those metrics that are going to drive those overall health outcomes, and that's where our focus is beginning to shift even now.
Would you agree with the 12 to 18 month time frame? Does that sound likely to you?
When I look in terms of where we're at today, if you had asked me 3 months ago, I might have said 12 to 18 months. I think we're really on a trajectory, and that progress that is continuing to improve, I would see us that inside a year when we come back, that we're in a position where we have a good discussion. Will we ever say that everything's perfect, that there won't be some individual or some provider that has a question that, you know, maybe we agree to disagree on? But that, from that perspective, we do believe when we look at the numbers today and the providers and the feedback we are getting, I have a list of comments here from providers that are very pleased with working with us. I have a list of members who are thoroughly excited about the services we've been able to deliver to them, some of them specifically citing things such as, boy, I've never been able to get this type of service before. Those are the types of stories we hope to continue to build that momentum so that we can truly demonstrate that we're moving in the right direction. We want to hear everything that our members and the providers and partners that we're working with, we want to hear their questions, we want to understand, we want to listen, and we want to work towards mutual and common resolution. But when we look inside of where we're at today and the progress we've made to date, it has been positive.
I'll add, there is not a claim problem that we cannot fix. That it's a really important statement to make. So so again, in the setup of things, you set up your system, you get the general, you know, the swath of issues, I guess, that have to be set up and established, and then you begin to work the detail. So of problems. So as you figure out, because sometimes it takes a little while to figure out what the problem is. So I know we had a home delivered meals problem. The system was set for monthly payments. It needed to be set for weekly payments. So we had to figure that out, get in there, figure it, fix it. And now we've paid those. I mean, it's an example of kind of working through then those kinds of issues. That doesn't then, and then we also simultaneously begin that process around systemic kinds of pieces, like I talked about with PMIC. I think we've all met on PMIC issues, and we're very motivated to try and figure that out. The rub of PMIC is the the view of what is institutional, and then when do we start moving to community, and how do we protect what we have and deal with that reality of there aren't a lot of other options? How do we hold that in place while we move to a day of supporting more people at their homes or in the community? That's the day we want to get to too. And so how do we make that work? You do that through work groups and the participation and the absolute interest on our part to be at the table to help figure that out. So in terms of your specific question about how long will this go, I don't know if I can give you a specific date. What I can tell you is, and you should count on that, which is you will see the numbers get better and better. You will feel that in the reporting that we do. I can't begin to impress how much time, effort, and energy, and I know the three of us in particular were very active, very involved CEOs. So this is not me just sitting there and just getting a report. We are actively grinding through day and night, and I mean night, that we work these issues. We want to know what they are. We want the problems to come to us directly so we can work it through. It doesn't mean they can't come somewhere else, but we want to be able to work through it. I think as Cheryl indicated, not only do we want people to know where to come and who to come to, I hope every provider, for instance, knows that. If they don't, they should tell us that. And we deploy the resources, we figure it out, we grind through it, and we get there. But again, it sometimes doesn't happen overnight in the type of question or the type of problem that is there. But it should, you would already feel when you see the next level of data, you'll see that improvement in front of you.
I do have one specific question I'd like to pose to you. This morning, I asked the ladies from DHS about when claims are rejected, if you are required to give a reason, and they assured me that you were, and yet after that, several people who testified here said that their claims were turned down and they weren't given a reason, and they had to really dig to find out what the reason is. I'd like to have your comments on that.
With every claim decision, a document called an explanation of benefits goes out, or a remittance advice, sometimes referred to that, and it tells why each line of a claim, if it was paid or if it was denied, and it gives a reason and an explanation code. For a claim that's rejected from a clearinghouse, to my knowledge, all clearinghouses provide reports.
Did you say a code?
Well, it's a code and then an explanation, code right by it, and then an explanation down below of what that code means. And then if a claim is rejected from a clearinghouse, the clearinghouses all provide reports for the providers to come back in, and the same kind of thing, it'll give them an explanation of why that claim was denied. And that's, to my knowledge, standard practice across every insurance company and every clearinghouse.
So,
Senator Garrett, we have several senators wanting to ask questions. Is that okay if we move on? And then we can come back and circle around if we have more time. Thank you. Senator Jochum.
Quickly. Okay, so the governor announces this January 2015, 19 months ago. You were supposed to be up and running January, and we seem to be having an awful lot of problems. To go to Senator Garrett's comment, you've been in other states, and I would have thought lessons learned. You would have worked out the glitches from the other states on a transition. We seem to be having an awful lot of them here from everything we've heard today. In the other states, however, the disabilities community and LTSS were carved out. So what other states are you currently managing where disabilities and LTSS is in their managed care system? Because quite frankly, from day one, I have said to Director Palmer, carve out the disabilities community. This system, this model was never designed for people with a disability. It was designed for people who are healthy or near good health to keep them that way. There is a reward for keeping them healthy. But we are dealing with a portion of our population, through no fault of their own, have very complex health issues. And there is nothing I have heard or seen so far that tells me that you have a clear understanding of the disabilities community yet. I still don't see it. So one suggestion would be carve out LTSS and disabilities. Suggested it to the department in March of 2015. When he said no, I said then phase it in, population by population. Start with the health and wellness plan, move to the Hawkeye kids, move down the line, make sure disabilities is the very last group, and take 18 months to do it. Nope, can't do that. Well, then we need a universal billing system and coding system so that all of these providers don't have to figure out 3 different systems, 3 different sets of codes, 3 different sets of prior authorizations. Nope, can't do that either. So yes, Senator, I think there's some things we can look at. Certainly we tried to terminate, didn't fly in the House. But there are some things I believe we can do to make the system work better, and those are just a few of my thoughts. Now, here's a question. Chapter 249M of the Iowa Code is the hospital provider assessment. And that, of course, is a program that pulls down additional federal funds, and that those dollars are supposed to be passed on to the hospitals. After hearing all that we heard today on the number of providers who have not been paid, sometimes inaccurately or incorrectly, or delayed for many, many months, I want to know what or how you are tracking the payments to the hospitals under Chapter 249 to ensure compliance under the Iowa law.
I personally cannot give you that specific answer today, but will readily, easily follow up and answer your question.
Good. Thank you very much, Cheryl, for saying. Cynthia, I'm sorry.
That's okay. I would have the same answer. I'm not familiar with the code off the top of my head, but I'd be happy to look into that and get back to you. Well, unfortunately, I have people that know those codes.
So I'm going to speak to what I do know, and then I'm going to tell you that we're going to follow up. So each month, we have worked with the state of Iowa, and there is a supplemental file that we get from the state that dictates specifically what we need to pay based on the assessments, the provider tax. And so that information is supplied to our IT folks, and it backs in through our finance team, where there are payments made to providers based on those assessments. Hospitals in particular, and so that particular transaction was established from the beginning. In fact, we submitted our very first payment on April 15th to the University of Iowa, and the first supplemental payment, and then providers have been paid each month thereafter. And again, that's a process we have set up. What I can't speak to is the very detailed specifics of all of 249, but I can tell you that we do have systems set up where we're exchanging information and those payments, and then we're verifying those payments back to the state that they've been made.
So if all of you could get back to us on the compliance, how to ensure to us that it's actually really happening.
And I can't say that's happening. I just didn't know the reference to the code. So, yes.
That is happening. I know that as well. That's happening, but and I can assure the compliance.
I'll talk about this later. Go ahead. I'm done.
Senator Johnson.
Thank you, Madam Chair. Thank you all for being here today. So, based on your comments so far, and I'm surprised that you're here to just take questions, then why don't we call the company store tomorrow, in each of your respective company stores, and get this $3 million shortfall taken care of now? What's the problem with that? I mean, what do you mean by that? I don't care about a data matrix. This nation and this state is founded on equal protection under the law. And so, you can tell me all the success stories, and more power to you. We're giving you a lot of money to do this. But there are people who are already having problems. So, value-based, does that mean that a patient under the care of a doctor is given a specific medicine, a specific brand medicine, and you come in and say, no, we're not going to authorize that. We're going to have you take a less expensive generic. Is that what you mean by value-based? And I don't need an answer to that, because I really don't know what you mean by value-based. Because if that doctor prescribed that specific medicine, in my opinion, you have to be a little bit careful about change, especially in some conditions of changing medications. How do you deal with that? I just don't know how you deal with that. Okay, let's talk about some things that maybe we can do tomorrow. For one thing, we can write those checks and get that $3 million shortfall taken care of. Can we do that? No. Okay. It's not a good start. Not a good start. Okay, so we have. I'm going to go back to my hospital administrator, who, says that because in some cases you require so much clinical information about a patient to get that patient admitted, that your online systems are not dependable. And so that requires either a phone call or fax. You know what that means? It means additional staff time going to meet your requirements, or the requirements of that contract, and not taking care of that patient and getting that patient admitted in the hospital. Can we fix that? Can we? You just really don't want to comment about that. Is this, I'm serious. Can't we fix that? Can we get your online system so that all this clinical information that you're requiring, probably some of it not even necessary to be admitted into a hospital? Can we do that? Well, because when you do that, that seems to be almost systemic to making the system fail and having these, having people fall through the cracks, it would seem to me. That's just my comment, not the hospital administrators. But again, and this has happened on a number of different occasions, is that the person who's answering for the MCO doesn't know the answer to the question, and the next person doesn't know the answer to the question, and the next person might know the answer to the question. So can we fix that? What's it take to fix that? 12 to 18 months or tomorrow? Could we fix that tomorrow? Go to work on that. You want to comment? Thank you.
I'm not totally clear, sir, on your question, but let me try that. So if you're referring to if a member calls us, so we have in our
No,
case,
I'm talking about a provider.
a provider. So provider calls. So I'm not sure. It probably won't be satisfactory to what you need. You are interested in having me say.
It's not what I'm interested in. And please try to understand
I
the
know.
perspective I'm taking. It's the patient's interest, not
Understand.
my interest.
Understand.
Okay.
Understand. So what I can tell you is that we have multiple ways of connecting to providers. We have multiple processes. We have multiple people. We meet with providers. We train providers. We work with them point by point on how to bill, how to work with them repeatedly. We have done outreach. We've done thousands of meetings. We have done all those kinds of pieces. We have dedicated representatives. We have dedicated resources to, for instance, the associations to make sure we're working through them very pointedly so they have one point of contact. So there are multiple ways that we reach out and are trying to work with them on their needs.
We're just looking for an answer to a question. That's what I'm referring to, is to say, can we do this? We have a patient that needs this. And the person on your end of the phone can't answer the question. And the next person can't answer the question. And the next person might answer the question. Okay, I want to talk about home health because Joellen was here this morning, and I wanted to talk about this now. And by the way, can we do something about him tomorrow? Okay, because you've heard his story. Let's get to work on it. Okay. So on home health, you just are really dropping the ball on this. What are you doing I'm hearing this over and over in Northwest Iowa. You really have no concept of home health. You came into this with no concept of home health, what we do here in Iowa with that. So this is an actual case. Patient goes to hospital out of state. And, that's been an issue with me because my district borders Minnesota and South Dakota. Is transferred to a hospital at the county seat town. But the patient doesn't live in the county seat town. Lives in a town a little bit farther away, maybe a 20-minute drive away. So he's had major abdominal surgery. He requires IV nutrition, requires a drainage bag that needs constant change or regular changing, whenever necessary. Could be a day, could be 2 to 3 days. The family's trained to do all that, and yet the MCO is insisting that this family, which hardly has the means to spend a little bit more money driving to the county seat hospital to have that there, to get the nutrition, to get the hospital stay, in fact, to get the bag changed. The family can do that, and that patient can stay at home. That person can stay at home where he's comfortable and where the family's trained. And yet, I don't understand why we want to insist on a higher level of care when we could save money doing this in home health. You know, can we start that tomorrow? Can we start working on that tomorrow and figure that out? Because it costs more to be in the hospital, of course. I mean, nobody would disagree with that. Doesn't that cost more? You'd agree that it costs more. The family's all trained for that. They can do the IV nutrition. They can put in the IV. It's got a port anyway, so I mean, everything's fine. But a very serious injury, but wants to be at home. This is what I don't understand. I really don't understand why we can't get through some of these home health problems, because we're going to have to face that more and more, because we got people who want to stay in their homes. That's a whole sea change coming. So I think I'll end it right there. I'm not going to get any answers. I really think, I mean, and then that was a good question, Senator Garrett. I mean, you've worked in other states before. Did anybody talk to this administration and said, you know, 9 months might be a little bit fast? I mean, where's this advice coming from? How can we take 560,000 people and put them into a system in 9 months? That's been my question and some of my colleagues' questions for a long time. But no, you know, we charged right in there and did the contracts. So anyway, I'm done. I know it's hard to believe. I'm not done, but anyway, thank you for being here. Okay, thank you, Madam.
All right. Senator Costello.
Julian asked my question originally, but I kind of want to address Amerigroup specifically, because I look at some of these payment times and you're significantly behind the other two. And is there a reason for this? And I would be motivated if I were you to try and get back with them. Is there something you do differently that maybe is making it look bigger than it really is? The one constituent that I've had that we haven't been able to deal with their problem is we're still working with the Amerigroup. So I'm concerned that you're maybe lagging a little bit. And so I guess my question is there a reason why these statistics don't look as good? And what are you trying to do to fix it?
Sure. It's a fair question. I would ask the same thing. So it's a first level report. When you see the next level report, you will see the improvement you will see at the same level. So what I'll say is, and I will speak for my plan alone. So in the process, in this shift to this, in this large system shift, so what you need to do is to be able to contract with providers. You have to bring them on board with you. Many providers, some significant ones, we were able to sign up they kind of held out, if you will, and we got them in. Thankfully, we met all the standards that CMS required, rigorous standards that CMS required, and in fact have, I think it's something like 98% of the network completed. And so, but when that happens, so you sign the deal, cut the deal, and then you need a lot of information from them. You need rosters. You need all of their information loaded in your system in order to do things like prior authorization, in order to do things like pay claims. So in this early stage, in this setup and in this build, that's the kind of numbers you're seeing. And so now that they're in, we're working through roster issues and all that kind of stuff. Those are seemingly long past, although just a couple of months ago, and so then you start to see then you see that churn in the number, and you see that drive then to be at the standards that we are required to be at. So, I mean, that is the absolute truthful answer, but I can go into more detail if you wanted to hear that. On rejected claims, we have a rigorous rejection piece because part of our obligation is to look for program integrity kinds of issues. We're not fully engaged in that in the moment, but as we build in that, that's another component piece that this is a different kind of system. It isn't the prior system. I think Director Steer talked about that, where the fee-for-service system is a pay, and then it's called a pay and chase system. Ours, the system that we are obligated to provide, is to ensure we've got contracts in place, ensure we're scrutinizing the claims, working with providers, ensuring the care. At the end of the day, it is about ensuring the care for the member, and members getting their care. So. So there are some technical components of that, but that would be the quick answer to your question. And I appreciate the question, because I would rather have it right on the table so we talk about that. Again, we are a company that operates very transparently. I will answer any question to my ability or bring it back to you if you have a question.
Okay, thank you. All the effort it's taking to get the prior approvals, is this something you'd expect to get significantly easier over time? There wouldn't be as many to do? I mean, that kind of concerns me because we want to make sure people get the care when they need it. Could you speak to that, please? I don't care. Go ahead.
The answer is yes. What tends to happen is everybody starts adjusting to the prior approval process from the beginning. What we saw in April and early May was everybody, or I shouldn't say everybody, a lot of people wanting to prior auth everything, whether we required it or not. So volumes were very high in those early months because it's that uncertainty of whether I need it or don't need it to get paid. What we're seeing now is a leveling off of that to the more stable number, only people wanting to only authorize what they have to authorize. That's a process that does continue to evolve because we learn a lot about the patterns of providers or care or the delivery system through those early times. And we've already made adjustments. We've dropped the requirement for certain prior authorizations after being able to work with the providers in certain situations. And that's a real give and take between the provider community and us, just to learn about each other and how we work and what we look for in those types of things. So that tends to, after the first few months, really stabilize and everybody kind of settles in to the process at that point in my past experience.
I would agree with my colleagues, but I would say that when I look at our performance in the first 2 months that you're seeing here, I'm proud of our performance with prior authorizations. We did work very, very diligently, very specific with providers to ensure that they got us that information they needed. And our numbers represent that when we look at that performance for those 2 months. And so we are absolutely committed to ensuring that providers understand what they need to get to us to get those prior authorizations completed timely, and we're communicating with them very extensively.
Okay, thank you. I have one last question. It's probably pretty simple to you guys, but what's the difference between a denied claim and a rejected claim? I'm not quite sure what that means.
Yeah, so there are definitions here on the page, but a rejected claim, for the purposes of how it's being reported, has been rejected from the front-end clearinghouse. So there are specific elements on the claim that clearinghouse has to have, and it's
The lack of information.
It's lack of information, and those top reasons are listed on the sheet as well.
Okay.
So those numbers will begin to decrease over time as
Right.
providers understand.
And people will resubmit those claims,
Correct.
presumably.
Those do not constitute a paid or denied claim until that comes in the system. So many of those claims could have resulted when they got resubmitted as paid claims.
All right, that's what I thought, but I want to make sure. All right, I think that's all I have. Thank you for coming and trying to answer our questions. I appreciate that. Thank you, Madam Chair.
Thank you, Senator. Senator Ragan.
I'm sorry. Can we address the question that Joe Ellen had about the notice of decision? Why are the notice of decisions not being sent out for waiver people? Are you aware of that? So people can receive the information so they know what services are provided or whether they're authorized for that?
So I can speak to it about some of the formal words, probably. I know that the state historically used a document called an NOD, or Notice of Decision, and that summarized the services people were approved or authorized to get. We do the same process, but we have different ways of communicating it. So we still do communicate it, and it's available to the case managers. It's just not in the same form. It's not called an NOD form any longer, but the same information is made available to the case managers to know what all services have been authorized and approved through the the utilization management process.
And then she also talked about, as a provider, I can also speak to this, that when you do get the notice of decision, it'd be nice to have something like a telephone number or some of the pertinent information that you need when you're providing services, and you may want to look into your forms on doing that, because when you get something and you have no idea, I mean, for me, it's not quite as difficult because I have one community, but I think there are some that serve a pretty good-sized region, and just hunting them down, that still adds to the administrative cost, as you would understand. So Senator Johnson talked a little bit about some of the things that you'd be interested in doing to maybe move things forward, to work together. And would any of you be interested in having a uniform form? I mean, we're talking about a lot of providers that are out there that are, struggling with having 3 different companies, 3 different forms. I know it's all electronic, but it would be nice, and I know even going through billing companies, it may be, clearinghouses are a little difficult, but I think that's one of the issues, and maybe you could speak to why we have to have it this way.
Sure. We have discussed that we will get together and look at the actual paper forms. I would point out that there's a lot of ways to do prior authorizations. You can call, you can do forms, there's online options for all of us. So I think we've all tried to make it different ways for what works for different providers. But at the same time, we have made a commitment previously that we would get to that and look at that. And I think we're probably getting near that time that we can sit down and go through that, because some of the learning we've had in these initial stages will help us sort of come to consensus on what might make sense.
Yeah, I agree. I think that's reasonable, and the department has talked with us certainly about that. We've talked with them, so I think that's, a reasonable thought, and I think the phone number piece is reasonable as well. I will say we all have national call centers for providers, and so there is that number there, but if you're speaking more on the regional level or that local level, we can think about that.
And just the final comment I would have is, 12 to 18 months. I guess as a senator, I don't remember in any of the hearings that we started out with that anybody mentioned it was going to take 12 to 18 months. I remember saying, we are ready. We were ready January 1. We're ready to do this. We can do it, no problems. I think somebody even said there was no bumps in the road. I can't remember who that was, but there was a lot of emphasis that this was ready to rock and roll, and we were ready for prime time. And 12 to 18 months might seem, for us sitting here that don't necessarily have a person involved, that might seem, okay, that's new business coming out and it's all got to get worked out. But if you're a provider, or if you're an individual receiving services, or you're the dad, or you're the nurse that's going for in-home care, 12 to 18 months is a long time. And I hope that we can do better as a state.
So I'll respond to that, because I made that statement, but I made it as in my prior life, that being a common. I was here for the startup of Magellan 20 years ago. I can tell you it definitely took 18 months to reach stability. I lived it. And there's probably some providers here who lived it as well. And the difference between being ready to start and then starting, I think I just want to clarify what I was trying to say, is that being ready to start means you're starting to go into that transitional phase of operating in the new world. And with all things where we transition into operating in a new world, we're still learning and growing and having to work together and have a shared responsibility to figure out how to make it work and be successful. So certainly, The earliest days are the most difficult days, and you get more and more under your belt as you keep moving. And I will say, it's hard to know, stable is in the perspective of the person you're talking to at the time. So, what I was trying to say was that things will evolve through the process. We won't be talking about billing issues most likely in the near future, but there may be some other new piece of it as program integrity items start up a little more, or other parts of the program start. It's all an evolution of continuing to learn and grow, and we have to do that together.
So hopefully at the first oversight hearing on the 29th, we'll have some updates, and hopefully things will be running smoother then.
Senator Bolkcom.
Thank you, Madam Chair. Good afternoon. Thanks for being here. So I want to come back to prior authorization for a minute. It's a conversation that we had earlier this spring about trying to have a uniform process for providers, and today I hear you're going to continue to think about it and see if that makes sense. I don't know how we're going to get your attention in any more dramatic way about this. We heard from the Hospital Association today that said they have physicians on the phone, they get inconsistent responses from the MCOs, they've added they got a lot of staff, and I think some of the hospitals were calling for prior authorizations for everybody, right? Every patient. So are you going to are we going to be back in August talking about this again? I mean, we talked about this in March as an issue that we heard from providers about having a uniform process between the three of you, and it sounds like that's still an unmet need. And I would even say this whole notice of a decision, that we ought to have a uniform way to communicate to providers and consumers whether they are approved or not approved to get services, right? And it sounds like, I'm going to guess, but it sounds like you each have your own language and your own forms and your own time frames to tell providers what's going on with that. So the other thing I would just note, colleagues, Senator Johnson, you asked, can't we pay this $3 million to this chain of, I'd bring Orchard Place in, can't we pay them the $1 million we owe them? And in the past, we'd go, if we had a provider that was owed $1 million, you'd pick up the phone and you'd call the governor's office or you'd call DHS and say, get this taken care of, and they'd say, we're on it, we'll get it done. Today, Senator Johnson, your question was met with silence from our new level of administration, right? I just want to point that out as an interesting thing that happened in the room this afternoon.
Senator, may I interrupt? So I would be anxious to set the record straight on one of the providers. I am reluctant to do that because it is a provider-related contract that we have, but I would love to do that, but I don't feel I can. There is another side of the story. For instance, what have we paid already to the specific provider who was talking about? It is millions of dollars.
Well, I guess we just want to make sure it gets paid, and they get paid
Absolutely.
the money they have coming to them. I mean, I think
Absolutely.
one of the themes here today, and I don't doubt there are specific providers that you're challenged with and them filling out the forms, and all that, but I think a general theme today is there's been a lot of 25% denials, and people are slow getting paid. People are going out and borrowing money to meet their payroll. I don't think any of you three companies are borrowing money this week to make your payroll, okay? So that I guess, be my next question is, what are you going to do to try and speed this up? I mean, we have Ma and Pa service providers out there that aren't Fortune 500 companies. And in the report we had, everybody's getting paid on, Mickey's telling us things are wonderful, but it's pretty clear when all 30% of the agencies are borrowing money to make payroll, there's an issue. And almost 90% are saying it's taken too long to get paid.
So, sir, I guess I would say that we have paid out $420 million in claims since we started on April 1st, and we have paid those with over 99% being paid within 14 days. And to Senator Jochum's point, some of those are in a day, and some of those might be in 13 days, but 99% of them have been in our contractual time frame of 14%. There are people who have claim issues, which, again, shared responsibility. To your point, there are billing issues of people not maybe filling out the forms correctly or sending information in correctly in a way we can pay them. And there are issues that we find where we may not have set somebody up right. And we work very aggressively to fix those issues as soon as we either identify them or it's brought to our attention by the provider or an association group or DHS or one of you, in fact. And we work quickly to fix those, and then we reprocess those claims very quickly if we have made an error. We continue to do that. We encourage people to call and tell us if they're having issues. We certainly don't have any desire for anybody to take out a loan, go out of business, lay off people because of our claim payment. And frankly, for AmeriHealth, I can say we've reached out and offered assistance in those cases where people have communicated that to us to avoid any possible situation of that happening. And we'll continue to do that as we all continue to learn. And you know, I completely agree the denial rates need to be lower. The number of times people are filing the same claim over again with the same information that won't allow it to pay is frustrating to a provider. It also drives the numbers up significantly. So when we can get all the communication and education and process really working the way it's intended to, those denial rates will come down, and I think that's probably a goal of all of us, to have those denial rates be lower than they are.
Home delivered meal, maybe it was it home delivered meals? Maybe it wasn't home delivered meals, maybe it was just congregate dining and paying for that. Maybe got up to 50, allowed up to 50, but one of the MCOs is only going to pay for 14 meals a month. Can somebody, in the company was noted, I didn't write it down. Was anybody in the room when that was talked about? Okay.
I might have to look specifically into that particular matter, but I think I had addressed it earlier here, which is just looking at how that making sure we've got the state policy interpretation of how to pay that. So we typically do it on a monthly basis. The policy is weekly, so we had to recalibrate our system based on what, you know, other states do it monthly. Iowa does it differently, that's fine, but as long as we know that, then we load it, figure out that problem, load it, fix it, pay.
So is the 14 days just, I mean, is our contract wrong in terms of how quickly you should be able to turn around? I mean, I think it was a pretty consistent theme here. People are not getting paid in a timely way. Maybe am I framing that wrong? If I'm not, but you're saying you're meeting the contract, and you probably are, but is it meeting the needs of our Iowa providers?
So the payment terms in Iowa are faster than, I would say, probably any state in the country. So when we think in terms of claim payment timeliness, and we'll validate that, but it is absolutely an aggressive time frame. When we look at many of our other states, they're at 30 days. And so when we think in terms of claim payment, I would not concede that we are not paying providers timely today. And we do have very specific data that demonstrates that. Are there providers who have not submitted claims correctly? Are there some configuration policy clarifications that we're having? Absolutely. We've paid out $245 million of checks that have been cashed, so dollars are getting in providers' hands. And so what we would say is we'd like to have really objective, thoughtful conversation, and let's look at the details. This is not the forum to look at those details, and we are aggressively working with providers who are encountering challenges to help them overcome those challenges. We are working with providers that have been here today with their billing folks daily to help them as a single claim is denied, helping them understand, reading that remittance advice, understanding what they need to do to correct that claim to get it in so it's a legitimate payable claim. all legitimate payable claims will be paid. And our goal is to pay those at a minimum of our contractual timelines, and in fact, we're exceeding those timeframes. When we look at the denial rates today, they are inflated denial rates. We will look, a part of program integrity is ensuring that it is a legitimate payable claim. We'll continue to do that, but we will work with providers because ultimately it is about ensuring our members get the services they need at the time that they need them, and at all times that will be our top priority.
Senator Bolkcom, may I move on? We have 2 more questioners, and then we're going to have to wrap it up. So maybe just one answer to Senator Whitver and Senator Siegebart. So Senator Whitver, why don't you go ahead, and then we'll do closing remarks after Senator Siegebart.
Yeah, thank you, Madam Chair. Thank you for being here and for answering our questions today. I know there's a lot of tough questions, so we appreciate it. Change is hard, especially when it's a magnitude of this, redoing the whole Medicaid system. And when this process started, my biggest concerns were 2 things. First of all, the patients. I mean, that should always be number one. Are we providing a seamless transition for them? And can we provide better services and better results? And for the first couple months, like everyone at the table, I received a lot of emails or calls from patients that were concerned or had issues. But I want to commend the department and Mickey and your staff, because every single issue that I brought forward from a constituent was corrected in 24 hours. Some of them very severe, but within 24 hours, those were fixed for the constituents of mine that got in touch with me. So I think that's extremely important. The second concern was the providers, because without good providers, we can't have good outcomes for our patients. And so that's where I think we still need to continue to work. And I know you can't answer the $3 million question today, but if you can get us an answer, there's still people that we represent and would like that answer, and maybe we can work through that. But I think the bottom line on all this is we're still early in it, and I trust that the next time we come together in a couple months, we're going to have less and less issues, and the bottom line is we all have to work together. This is our system, and we all have to work together in a constructive way, and so I appreciate you guys coming and answer those questions. Thanks.
Whitver. Senator Siegebart.
Thank you, Madam Chair. And thanks, guys, for being here. I know you're doing as good a job as probably anybody could do that's been put in this position. What the state has done is hired 3 insurance companies to pay for the services that our disabled people require. I mean, that's the base of it. And the regular insurance companies that insure the rest of us seem to do a pretty good job and don't have these problems. So if you could model after that system, which I'm sure you do because you probably all provide that same insurance anyway, keep doing, just keep working on that. And I can't overemphasize the fact that our providers are key to all of this. If you need on your dashboard, and I've talked about this in the past, you need a big red light that goes off if you have a provider out there that hasn't seemed to have cashed a check in 3 months. It starts flashing or beeping or whatever, and send somebody out there and see what's going on. Why aren't we getting that accomplished? So that's my first point. The second point was Jeff and son Colin ripped my heart out like this committee usually does and laid it on the table. I've been suffering ever since that. But Jeff asked the question, why can't clients belong to all 3 insurance companies at the same time? I don't know why. Is that possible, or is there a restriction to do that? And if he could, how would that help him out? And maybe he has to answer that. How would that improve his quality of care there? So the question is, and I don't know who knows the answer, maybe Mickey knows the answer to that. Can one client belong to all 3 insurance companies? Why did you just have to pick one? I'm sorry, man.
Coordination of care, making sure that the member has an MCO that is their medical home, and that there's a case manager within that MCO that would coordinate that individual's care.
Okay. You ripped my heart out again. So, well, and I like the carve-out idea. I think that's great. So that's my question, my comment. So.
Wow, this has been a long day. More information. Here are my closing thoughts, I guess, I have no doubt that Kim and Cynthia and Cheryl and Mickey and Liz are very smart women, and you know what you're doing, and you're trying to move this along. And as Mickey has told us several times, we are all on the same page. We're trying to move a patient forward to make their health better, whether it is the disabled community or whether it is the healthy community. That's what the objective of this is. However, we have fallen short in this transition, and we have fallen short in the area below all of you. So in the level of maybe the managers or the people who are answering the phones or the people who are, answering the questions to some of these complex questions, that's where we're falling short in the communication systems around this, and you can feel that. And from all the testimony today, that's what people are frustrated about. So I would ask you, as leadership, and you all have a vision and you know what it's supposed to look like, and you know you have the metrics and the matrix, and you know what you're supposed to do, let's work towards that. Let's really, really work towards that in the next 30 days. Now, somebody said, I'm not going to put a deadline on it or a timeline. I am going to put a timeline on it. There should be a work plan, just like we do at work. You need to have a work plan and a timeline, and this is what you're working towards. In 30 days or 60 days, we're going to get the billing issue solved. We're going to get the pre-auth solved. We'll get the reimbursement solved. Whatever that issue might be that surfaces. So Liz and Mickey, you know more than anybody what, according to the data, you will be able to see where the flaws are and where the gaps are. And I would really like to see you work with the MCOs and come up with a timeline when these things will be solved. And they need to be solved more immediately than we're saying 12 to 18 months. They really need to be solved, because what's happening on the lower part of this is people are closing their shops. People are laying off. We heard, one nursing home chain has already laid off 20 people. It's very hard to hire direct care staff. It's very expensive to train them. You'll be paying for that. And we'll be going around in a circle. So with fewer services, it's going to be harder to get those services, and we're leaving people out in the cold. So my number one objective for you is to put some of these issues that you've heard today. I know you have your own path. You know what you're supposed to solve in the next 12 months to 18 months. But take some of these issues today, uplift them, and try to solve them in the next 30 to 60 days for these providers. We've got to get to it. We cannot leave people behind here. I think we all understand, from the provider's perspective, they could be doing things that are wrong. Yeah, absolutely. Filling out billing information without a name or an incorrect number, whatever it is. But keep the communication lines open. Let them know that they're doing this incorrectly and consistently incorrectly, and send your rapid response team out whenever you can, and more often than you are now. So some of those things around that, try to change that in the next 30 to 60 days, because it is going to be a make or break. It's going to be a make or break for our state. Number 2, is Ann Starr still in the room? Okay. I want each one of you to set up a personal meeting with her, go to Orchard Place if you haven't already, and solve her issues. Please, if you have already, it's not working. Please go and solve these issues with her. She's dealing with children, so please do that. And I want to know, by the time the oversight meeting meets on August 29th, I need a resolution. I need a solution to her problems. We all do. Get it done. 30 days. Number 3, has anyone ever sent you to collections? Has anybody in any state ever sent you to collections? Because I know that there is a group that is ready to do it. And so we're going to have a firestorm here. We don't want to have that happen. That's going to create a whole new layer of issue. And so unless you want to be sent to collections, we've got to solve these things, and we've got to solve them more immediately than we're doing right now. And lastly, our next meetings will be, we only meet once. So Senator Whitford, you were saying maybe in subsequent meetings, this, before you came in, this committee can only meet once out of legislative session. So this is the first and the last time that we'll be able to address you on these issues. And that troubles me, because when 6 months goes by, you know, we might not be able to shine a light on things the way that we need to. But the next meeting for oversight, for the Health Policy Oversight Committee, has been agreed on as August 29th. Prior to that meeting, we'll be meeting with providers and advocates and consumers at what time? We haven't decided. So there will be an opportunity to just meet before that meeting, and that meeting will be scheduled at 12:30 to 4:30 that day. So we will be asking, I think you probably have it on your calendar, we'll be asking the IME, DHS, and the MCOs back again, primarily on taking a look at oversight language and how that oversight language that was passed on July 1st, how that applies to what we're doing today, and if we can make sure that we're adhering to that oversight. Okay. Lastly, thank you for coming. You have a tough job. You really do. You have a very tough job. This is a big job. It's a lot of money and a lot of people and a lot of information, and you have to adhere to HIPAA. You have to adhere to a lot of different policies and protocols, and we understand how complicated it is. So thank you for coming, and coming before this committee and answering the tough questions that have to be asked by us. Providers, those who raised your hands and those who didn't, and consumers, thank you for coming and plugging into this and tuning into this and just being aware of what's happening. Keep us informed as legislators. That's how we know if things are working or if they're not. And we will continue to move some of this information around. Paige Thorson, thank you. Paige works for DHS and IME, and as we get either, you know, things that need to be solved, we send those to Paige. And you're right, Senator Whitford, they have been very quickly either resolved or answered, or something or someone has gone out to work with the people that are having issues. So continue to have connections with your legislators. I get a lot of emails, so not just me, but try to find your own senator in your own district too, because they need to know what's going on with your business, what's going on with you as a consumer. They need to know too, because otherwise when we come back next session, they're going to be clueless about what's going on here, and they're going to have to vote on some changes and some things that we'd like to bring up as legislators. So keep in touch with your legislators, all right? But you shouldn't have to always go to your legislator to get a question answered. And we don't want to make that tough. We don't want to put obstacles in people's way. We want to make sure that there's good customer service and good consumer benefits. So thank you all for coming. I appreciate it.